Next, please help me welcome Dr. Andrea Gropman of Children's National Medical Center in Washington, D.C. Dr. Gropman is a child neurologist and clinical geneticist. She's the PI of the principal investigator of the Urea Cycle Disorders Consortium. Her research focuses on establishing biomarkers of neurological injury in patients with inborn errors of metabolism. These biomarkers help us understand neurological injury and how it happens and accelerates the study of treatments. She's going to be talking today about emerging knowledge from MRI imaging studies. Is ammonia control enough? And both Dr. Gropman and Dr. Nagamani and Dr. Burge will be here for a panel, so you'll have a chance for questions.
Thanks so much for the opportunity to be here, and this is really special meeting for me because we're honoring Cindy. Sorry, I'm going to get a little emotional. I wouldn't be here if it weren't for Cindy. That's what I looked forward to every time I came to the conference, was catching up with her, although we did talk a lot on the phone, which, as you learned, is her favorite mode of communication. She didn't like to do video chats, and often during our PI meetings, she would have the camera off with her little picture, and it was like her speaking behind the screen. But when she spoke, everyone listened because she was full of knowledge. And like Sandesh, I was taken into the fold. So I was a child neurologist originally, and then I was able to negotiate with my fellowship to spend 6 months doing basic research at the National Human Genome Research Institute because I was interested in genetic neurologic diseases, and that's where I fell in love with metabolism. So without skipping a beat, and probably much to the chagrin of everybody because I wasn't going to be getting a job next, I completed fellowships first in clinical and then biochemical genetics. And then, most of us came into our careers somewhat by serendipity. There was an opportunity to participate in a mentored clinical research program, and they had just built a new MRI center at Georgetown. And so Mark Batshaw thought, well, we have a lot of questions about neurologic outcome in patients with urea cycle disorders, and you have an interest and you have a neurology background. How about if, you focus on that? And then I think the rest is history. So I'm going to go through some of that history and some of our current studies. And, I'm looking around the room, and I have to thank those of you who participated in these studies. I mean, I saw someone who, I don't know, was it 2004 or 5? You were one of the original number 2 patient in our first 5104 protocol. And then Amanda, coming out to Pasadena when, but again, by serendipity, finding a mentor who had done all this in hepatic encephalopathy, which is somewhat the non-genetic cousin of hyperammonemia. And then how ironic that the NUCDF would then years later be in Pasadena. So thanks, everyone. So I'm going to talk about what knowledge we've learned through MRI and other subsequent studies and whether we think ammonia is everything. And I also have to thank my colleague who is doing some studies right now with non-invasive imaging, Kosar Kaksaki. So again, I brought her into the fold. She's a biomedical engineer who had a technique that I knew was going to be valuable. She didn't know anything about biochemical disorders, and now she's probably the only biomedical engineer expert in the field of inborn errors. So I want to review some of the work we've done. I'm going to talk about our work in all the subjects, focus on carriers, that's of OTC, which is a particular interest. And then because you all asked, how come your studies you can't do younger children, we started to focus on the infants. So I'm going to review some of that newer data and some of the lines of evidence that it's not just the ammonia necessarily contributing to neurologic outcomes, and then again talk about some new areas of investigation. So I don't have to tell this audience what a UCD is, but we have to educate our colleagues that these symptoms can really present at any age. It's not just childhood onset. And the consequences of neurologic outcome can vary in severity. We see the neonate often with the most severe disabilities, especially for OTC, CPS1. Childhood, we have a broad range. And then I'm particularly interested in the adults because many of them are misdiagnosed as having psychiatric disorders or never diagnosed, tragically. And unfortunately, every year we do hear about young adult who's passed away because a urea cycle disorder was not being considered, or if it wasn't acted on. And so, ammonia is harmful to the brain, and the levels can remain elevated for extended periods of time while people are getting to the diagnosis or getting to the therapies. And as you heard, decades ago, there really wasn't any testing or care to monitor hyperammonemia, and especially its impact on neurologic function. We just knew that individuals had a high rate and a high risk of intellectual disability. And so the common theme of at least the proximal and some of the distal urea cycle disorders is this high ammonia. And so what happens when you have a high ammonia in your blood? Well, there's no blockage or stopgap in terms of it getting into the brain. So if you have a high amount in the blood, a high amount can get in the brain, and there's no pump to get rid of it, or there's no safety net to get it out immediately. So patients can present with changes in their mental status. They become sleepy, combative, they can have seizures. All the while, there's some swelling in the brain if we don't act immediately, and there can be tragic results. So the consequences of hyperammonemia, whether they're changes in behavior, mental status, all the way to unresponsiveness, we refer to as encephalopathy to encompass all of that. That's the medical term. And the signs may occur even at lower concentrations of ammonia, and it's different for each person depending on which disease they have, how much residual enzyme. And so, we start to see some signs possibly in patients with levels maybe just over normal, and others maybe into the hundreds or thousands. And some patients may tolerate higher levels before we see symptoms, or the initial symptoms may be missed. And the short-term changes could be, anorexia, they're not eating, become irritable, lethargic, somnolent, disoriented, vomiting, and then asterixis, which is that flapping tremor. And so how can neuroimaging contribute to understanding some of the pathogenesis and also help us monitor and possibly monitor some of these newer treatments that you're going to hear about? Well, in the past, I was a little bit naive, and I thought once I got into the Urea Cycle Consortium, the very first project I was going to do was to collect all the MRIs on every patient who had a urea cycle disorder and look and see, what changes there were. But that wasn't the case. MRI was not done routinely, if at all. Someone was in a coma, it was just assumed this is part of the disease, there's nothing to do or nothing to learn from it. And so decades ago, having a UCD really meant severe disability and possibly an early death. And so, we started to understand the relationship between high ammonia, and it can be stored temporarily as a compound called glutamine, but the glutamine level in the brain can be different from the blood. And so there evolved neuroimaging methods where we could actually measure the glutamine concentration in brain, something that we couldn't do before. And so, we knew that with this increased glutamine, there was brain swelling, there was increased pressure in the brain, there was increased free radicals, mitochondria were swelling, activation of different neurotransmitter pathways causing cell injury and cell death, but that most of the changes in urea cycle disorders focused not on the neuron or the brain cell, but on a supporting brain cell called an astrocyte. And so, over the last 20 years, I guess it's been now, taking advantage of the different types of MRI that came online, we could see in some cases there might be very small changes initially. So it's very difficult in the early days to diagnose a urea cycle just by an MRI scan because it might still be normal by the typical scanning. But, if you look at spectroscopy, which is a measure of the chemistry, and in particular the glutamine, and I feel spectroscopy was made specifically for this disorder because the three metabolites of interest that we want to see, the glutamine, which reflects your ammonia load, the myo-inositol, which is the attempt at buffering, and the choline, which reflects your membranes in your brain and becoming dysregulated, can all be seen here. And then for certain patients, we were able to look at what happens to the tracts in your brain. And so we use something called diffusion tensor imaging because the membranes were being broken down. We could reflect some changes. And then we also looked at the function. So many patients were reporting problems with memory, with attention, and this research had been done by Dr. Batchar and colleagues. But now we had an actual physical map to show where those brain networks are that aren't working, and why does somebody have problems with multitasking or remembering things or making decisions. And then some of the work I did with Dr. Ross that Amanda graciously participated in was looking at the actual turnover of glutamine using a non-radioactive isotope. So being in the scanner for a long time and getting an IV and following it through that Krebs cycle that Dr. Nagamani talked about to look at how much glutamine someone was actually producing. So we did those studies as well. So this is representing the last 20 years of imaging research. And then, of course, we want to understand what happens after someone has hyperammonemia in the recovery process. So waiting for the opportune time, we were able to study a long-term patient who had been quite stable and then unfortunately succumbed, he had the flu and had a major hyperammonemic decompensation. And so we found new information. So this was a patient with OTC, and we thought it was all in the brain and the memory, but then lo and behold, we found that also some of the fiber tracts going to his legs were disrupted as well during this prolonged and protracted recovery from hyperammonemia. And we studied him over 2 years. So we had several MRIs in the early days. I remember the family was very gracious, and they had his braces removed because if you have braces, it cuts out the frontal lobes as a metal artifact. They said, no, we want to be in this study. Call the dentistry consult. We'll take the braces off for now. So it was just the wires. So we took the wires off. And yeah, we followed him over 2 years, and we saw some new changes in the motor strip that we didn't know. So we learned new information. And then, using these investigations of the multimodal, so the regular MRI, which we call the structural MRI or T1, T2, the diffusion tensor, the spectroscopy, and the fMRI really held promise for understanding all of what ammonia and other molecules can do to the brain. And so the MR spectroscopy was used, and we found that there was an elevated glutamine. We also found in the carriers. So we had a number of OTC carriers, some that had symptoms, some that didn't, but nonetheless, as a group, they had elevated glutamine in the brain. It wasn't as high as those who had symptoms, but it was definitely higher than normal patients who don't have any metabolic disorder. So we thought, can we use this to diagnose those with a partial deficiency? And then with the functional MRI, and now with something called functional near-infrared spectroscopy, we can look at local changes in brain flow and oxygenation and see what pathways and what networks are disrupted that may underlie this executive dysfunction. And so now we're using a non-invasive technique called functional near-infrared spectroscopy, and we compared. We had patients who had done the full fMRI and patients who had done the FNIRS, and that was at our DC conference, and we found that this non-invasive, very portable method of looking at brain connectivity can be a surrogate for the fMRI. So now we could look at the infants and the young babies. And so patients who are treated, as you heard, still have cognitive issues. So earlier diagnosis, improved management, and nitrogen scavenger therapy have improved the lives. But many patients still have learning disabilities which fall under the umbrella of executive dysfunction. And so what does that mean? Self-regulation or inhibition, working memory, cognitive flexibility, problem solving, and planning. And so my research focused on OTC and arginase deficiency using the non-invasive technology and now with devices. And so we wanted to understand the relationship between ammonia, glutamine, cognitive dysfunction, seizures, and their impact on working memory in particular. And so I did say I would talk about the carriers. So when I entered the consortium, 85% of female heterozygotes were said to be asymptomatic based on history, and only 15% showing symptoms that were overt. But our research really has demonstrated otherwise, because improvements in brain imaging technology allowed us to show these intermediate changes in glutamine levels, some intermediate changes in working memory. And in fact, we had developed and published a stress test, if you will, where if we push someone on cognitive testing, we started to see at the higher levels of difficulty that some of these women would demonstrate the executive function changes that we saw in those individuals who were overtly affected. And that goes along with the history, is that they may be doing well, but then when there's a stressor, we start to see some of these changes. And so this, I think, was one of our most exciting findings, and Dr. Ross really liked this finding, so this is a superimposed spectrum of, it was two sisters actually. One, they both had OTC gene variation, mutation. One was symptomatic from age 2, the other was asymptomatic, and then there was an age-matched control. So the control's in green. The patient who was symptomatic, if we look at a few areas. So again, the N-acetyl aspartate measures the neuron, the brain cell activity or integrity. And so we see there's no change there. So it's not a problem with the neuron. It's a problem that occurs in that astrocyte. And so we see the increased glutamine in the affected sister and a little bit in the unaffected. The choline, surprisingly, was decreased in also the unaffected. And then I think the most striking was this myoinositol. So this is your buffering capability. So a nice normal peak in the normal control, low in the individual who had suffered multiple hyperammonemic episodes. And in general, we saw an inverse relationship between the glutamine and the myoinositol, high glutamine, low myoinositol ratio that was consistent throughout. And then this intermediate level in her sister who is asymptomatic. And then we looked at executive function, and this is from that paper I described, is that, we use a number of tests. So the Stroop test is where you have to name the color. So there's a word, like the word yellow may be written in yellow, or it may be written in black, and you're asked to just say the color, not to read it. So that's an inhibition test, because we're so prone to read that we want to blurt out, yellow. It's like, no, you're supposed to say black. So that seems to be a discriminatory task for this condition. And then we also looked at digit span backwards, which is a simple attention task, and some other tests that you've probably done, IQ testing, et cetera, language tests. And we found that there were a few tests that were characteristic in bringing out the deficits in the carriers. So one is something called the trail making. I call it the adult dot to dot, where you have to connect numbers as quickly as possible, and then there are distractors thrown in. And then some of the numbers are written in words and some are the symbol, and doing it as fast as you can. And so trail B is actually the hardest one. So you can see that our symptomatics, this is a time test. We're slower. Our controls, we're pretty quick. And then in between were our so-called asymptomatic carriers. So the discovery that asymptomatic carriers can demonstrate cognitive deficits was really new information, although for many of us probably not new, and for you probably not too. And so this was something that we wanted to look into further. And I remember I was at, I don't remember what meeting, maybe Denver. I was in an adult focus group. I said to Cindy, where should I go? What do you want me to do now? She said, go into this adult group. And they were talking about driving, right? I walked in, they're talking about driving. Do you drive? Do you drive? And it seemed that driving was a difficult task for many. They struggled with not only the motor dexterity, but also the lots of information coming in at once. People didn't want to drive on highways. They would drive to work and back. They would avoid driving at all costs. And we thought, this is probably something we need to study because it's real-world evidence of executive function at work. And as patients are getting older, this is a milestone of independence. And so, we talked about the stressors with the Stroop test, and so driving was the next frontier. And we believed that the patients may only show difficulties when the tasks required planning and physical movement and when they became challenging. We saw this during the imaging when they were pushed to do the harder and harder tasks. And so I'm going to talk to you about the driving that we're doing. at the end of the talk. But many of you said, well, what about the babies? What about our small children? They can't participate in these studies because you set your age limit at age 6. So we developed the FNIRS technology. This was work that was being done at NIH, and it's basically a cap. So you have two things going on. You have a detector and an emitter, so there's different colored probes in the cap, and it uses light. And so when you perform a cognitive task, oxygen is extracted from the brain to go to those neurons that are performing the task, and there's a change in the wavelength of light, and we can make a color map and see when you do this task, what areas of the brain light up, and when you do that task, what areas light up, versus normal controls. And this has been worked out, and these tasks have been worked out in normal control populations so we can compare. And so we basically were able to compare. So here's some of the maps we can make with FNIRS, as well as different disorders that have been studied in the past. And the colors refer to the intensity of the signal. And we were able to compare that with functional MRI and show that we saw the same areas impacted. So now, for those of you who are claustrophobic, we don't have to do the fMRIs anymore. We can do this portable device. You can move your head, and it doesn't degrade the image, and it costs a lot less than 1 hour in the scanner, because once you buy it, you got it. And then, what about the babies? So this is the old way that we used to monitor ammonia and seizures and other things in our babies, is we would do these very careful plots of glutamine and ammonia. And this was my colleague, Tay Cheng, who inspired this work and unfortunately passed away a few years ago. But then technology came in, and we thought, well, let's use the technology to help us with neuromonitoring. So neuromonitoring became a thing, but it wasn't a thing for inborn errors. And so wanting to push the envelope and bring it into the fold, I thought, well, let's look and see if this will be useful in our patients, particularly our hyperammonemic babies. So we bought a few of these monitors called the Moberg device. It's a fancy monitor, but the feature is it has lots of plugs, so you can put in all your different monitors, your heart rate, your respirations, your EEG, like all different types of things, and you can look in real time and see how they all change. You can give a medication and mark it and see how that changes. You can get labs and then put all the lab values in and see how everything changes in real time and understand how those changes relate to the underlying pathology that's happening in the brain. And so some of the things that we saw was, when we hooked in the EEG, is we got some nice healthy brain waves, but when we looked at the hyperammonemic babies, we saw these long pauses in the EEG where there was decreased brain activity, and the higher the ammonia, the longer the pause. So now we had a bedside monitor to be able to inform clinical decisions, because I can call NUCDF or whoever's on call for genetics, and we can say, look, there's a change in the EEG. We think that the patient's ammonia might be going up. So can we check it now as opposed to 1 hour, which is your protocol? And so doing that, we found that the EEG monitoring revealed a lot of silent seizures, mainly from the back of the brain in these babies. So these babies are lying there in coma, not doing anything, no movement, but they're also seizing. So, seizures need to be treated, particularly in the newborn period. There's a large neonatal seizure network that has shown that neonatal seizures can cause changes in the different brain networks and cause developmental issues later on if you don't treat them. So now we could do precision medicine. We could look at one baby with a situation and treat that one baby instead of making decisions as a group. We could do this at the bedside. The other thing we saw was something called an increase in delta power. So there are different types of waveforms on the EEG. Some are fast, some are slow. The delta are very slow, and so usually we see delta with prematurity. It's a developmental stage in terms of your brain waves getting faster, but we also see increased delta when there's been an insult to the brain. And so now we're looking at the delta could also be a monitor of how things are going for the baby in terms of their initial and then their later cognitive outcome. And it's also associated with sleep. And so this is sort of what I talked about before. If you look at different levels of ammonia, and these squiggles are all normal, and you can see as you get to higher ammonia levels that the EEG is almost flat. So seeing the change in the EEG progressively to flatter and flatter background, alerts us to intervene at that moment. And we weren't doing a lot of these bedside EEGs, decades ago. And so we can also make correlation maps with ammonia and this delta power and give us a sense of what parts of the brain are affected and how much ammonia there may be. Showed that. And so how does that information help? Well, basically, if we see the evolving EEG changes, we can make medical decisions in the moment. And so back to driving. So as you know, the driving requires a lot of cognitive skills, executive function, a lot of information processing. There could be drowsiness involved with long drives, distraction, lack of attention, anxiety may be the main reasons for car accidents. And so, not to do it in a negative way, we want to figure out why this is happening and maybe develop some sort of remediation so people can drive and be better drivers. And so there are several research groups studying driving, mainly in patients with Alzheimer's or degenerative disorders. But as far as we know, not anyone in the inborn errors. And so we thought, well, we can do a driving simulator and look at errors and things, but wouldn't it be cool if we also paired it with the FNIRS so we can see what's going on in the brain while they're driving? So the objective of this project is to examine biomarkers while driving using FNIRS. And so this project is rolling out. We haven't really started it yet. So this is what it would involve. So you wear the cap again. We have a driving simulator. And so we're measuring information as the driving gets sequentially more difficult. And so we've used some of what you told us. So I always like to listen to the patients and to the NUCDF to drive the research. Things you told us were difficult, we put into the driving scenario, but we also coupled it with some aspect of executive function. So decision-making, distractibility, it's all built in there. There are like 3 or 4 different levels of driving difficulty. And so the first level are gentle curves, and you experience driving with low demand. The second level, you have higher demand. You go through a road work situation with narrow lanes, which is realistic, right? Sometimes there's road work and the lanes switch and can be anxiety provoking, so that's intermediate. And then the third level, you have a forced lane change, and you have to execute an additional lane change, and then you have to activate brake lights. And so we're trying to do more and more complex but real world type of challenges. We also have one with weather changes that we can implement and a pretend passenger in the front seat, because we also heard that just someone sitting there was pretty distracting even if the person wasn't talking. So we want to make it as realistic as possible. And so lastly, I wanted to acknowledge all the people who have contributed in this work over the last 20 years. My lab members have changed. So my recent lab, Dr. Koksaki, who is the engineer, and she's very interested. I know she asked a few of you about your driving experience so she can improve on it. Wei Liang Chen is a triple threat. So he, in addition to being a neurologist and a clinical geneticist, he's also an epileptologist. So he's really helping us with this neuromonitoring. Kuntal Sen is another neurologist that he started as a geneticist, and I convinced him that he should also do neurology, so he's doing neurogenetics. Alexa's here. She's one of my senior research coordinators. We also have Anna and Karis. And then Chan, because we can't pronounce his name, Chan is a visiting child neurologist from Thailand, and so we're hoping that we've piqued his interest in urea cycle disorders, and when he goes back, he's going to help set up networks there. And then all of our collaborators on the neonatal study, and in memory of Tay Chan and Cindy. And then I have to acknowledge the funding from this Urea Cycle grant, also the O'Malley's and Ketterings. And so if you're interested, this is my shameless plug, in our driving studies, contact Alexa or find Alexa or Kosar here at the conference. Thank you very much.